In the middle of desperation, another potential crisis may be brewing.
This is not a small place, it's the whole island. And the problem with the diesel and the gasoline, we are trying to work with these people. We are trying to still providing services to these people.
Dr. Maria Rodriguez has worked at this community health clinic for 24 years. It's one of 70 such places all across the island which serve as the front line for preventive health care. Everything from broken bones to counseling to pharmacy services for many Puerto Ricans. But as fuel dwindles, so will care.
In a way that if we continue to provide these services in this area, we stop the patients go to the hospital that is already overcrowded.
They have been told that they have just 6 hours of fuel left. And at that point, without any help, they will have to close their doors.
What else we can do? The only thing we can do is go into the shelter, do the medical evaluation, but we can't provide medications to those patients.
And that's in part why you're seeing tents like this pop up in places like San Juan. You see, even before Maria, a third of the population here was reported to be in poor health. They're more likely to be older here, more likely to have chronic disease like hypertension and diabetes. And therein lies the concern. What happens to all these patients if they don't get access to care within the next several days? Getting healthcare services up and running is key, but the only way to do that is to make sure clinics like this are powered with fuel. And right now, that's a big unknown. Domingo Cruz, director of San Jorge Pediatric Hospital, knows just how critical it can be. Just 2 days ago,
the hospital was dark, and all of a sudden, as you may understand, everybody was very nervous, and we started evaluating transfers, possible transfer to other hospitals, patients that could have been discharged home earlier than what it was initially perceived.
They were running low on fuel, just 2 days worth, and a dozen children on ventilators.
We were ready to evacuate the entire hospital if we didn't get power somehow early afternoon.
A neighboring hospital brought 1,200 gallons of fuel. And then yesterday, a U.S. Army tank provided 3 more days worth to keep this generator going.
It was a close call, and we thank God that it worked out.
It's been trying professionally as well as personally. In the midst of the storm, his mother passed away.
Very hurt the day of the storm. The day after the storm, I showed up here. We need to be open. There are people looking for us.
Ladies and gentlemen, please welcome Sinsi Hernández-Cancio.
It's almost like praying.
Buenas tardes. Thank you all for being here. I know it's the last plenary of the conference on Friday, and I really appreciate you being here. Before we hear more about the current crisis with some fantastic experts that we have and what we can do about it, and especially the lessons we can learn from that experience, I want to provide a little bit of background. It's been 128 days since Maria hit Puerto Rico, more than 4 months. And there are still nearly 500,000 people without electricity. And it's not just in the remote rural areas of Puerto Rico. For example, my wonderful in-laws, and I say that with no sarcasm, I love my mother-in-law. She's in her mid-70s. She lives in a San Juan suburb. And they have had no electricity for 142 days because they lost it when Hurricane Irma hit before Maria. These are US citizens. But in fact, almost half of the United States population doesn't even understand, doesn't know that Puerto Ricans born on the island like me are born citizens. And we are citizens whose health has been undermined for generations because of discriminatory federal policies, particularly in health, education, and welfare. For example, it wasn't until 2001 when Puerto Rican children were counted as whole children in Title I education funding. I'm not sure if it was 3/5, but the formula did not count every child as a child until just 17 years ago. And many people don't know that this wacky new idea of having block-granted Medicaid programs is not new at all. Puerto Rico has had a block-granted Medicaid program for 50 years. 50, not 15. And what does this mean? We have a healthcare system that basically grew in Dr. Camara Jones' pink box, not the red one. It's been chronically underfunded. And before we get into the details, I think it's important for all of us to know what it looked like before Maria, before Irma. I've already talked yesterday a little bit about how my dad, a primary care physician in Puerto Rico, practiced medicine by barter. But I didn't talk about the rundown hospitals. When people who actually have money get a serious illness, they hop on a plane and go to the States. We're talking about hospitals where nurses take collections so that their patients can have soap and lotion and powder. There is a cottage industry of people paying women to sit with their family members in the hospitals to make sure that someone is watching and they get the care they need. And it's not because the nurses aren't awesome and that the doctors aren't great, but there's just not enough money in the system to pay enough of them to provide the kind of care that people need. And when you go to the hospital, you have to bring your own blankets and your own pillows, and it's just a vastly different experience than what we have here in the States. And there are no nursing homes. There are no skilled nursing facilities, not a one in Puerto Rico. I want to tell you what this means to a family, and I want to tell you what it means to me. As a mom with a 2-year-old who was in Puerto Rico working back when I was working for SEIU, and my kid was coughing and hacking, and he was asthmatic, and I'm a person who had one of those Cadillac insurance plans because I worked for a union. My dad was a doctor, so I had a whole network of doctors to rely on. I have a passing understanding of medicine and healthcare. And my son was super sick. I talked to a friend doctor who said, I'll see him at the Children's Medical Center in San Juan, which is where she practices. You won't have to go through the bureaucracy, you won't have to go through the red tape, it's just where I'm gonna meet you there. And I took my sick little baby, and she checked him and said, he needs an x-ray, because I think he has pneumonia. So he got his x-ray. And then I asked, so does he have pneumonia? I said, well, I don't know. I'm not sure, it looks like it. I said, what do you mean you don't know? Where's the radiologist? And she said, the Children's Hospital doesn't have a radiologist. The last one we had left to work in the States. So what do you do with all these children? Who reads their x-rays? Well, we have a process, and we send them over to the adult hospital, and it's not the best thing. She's on and on about how difficult it was going to be to simply get an x-ray read for a child. I was lucky. I said, give me the x-ray, because I know at least 5 different radiologists who will do this as a favor to me or my dad. And I find out that, yes, my child had pneumonia. That was in 2008, before 1 doctor a day started leaving Puerto Rico. And as we learned yesterday, we said this, many speakers talked about, this kind of stuff doesn't happen by accident. Maria could be considered an accident of God, or an action of God, a force of nature. But decisions about resources and who gets what is not an accident. The healthcare system in Puerto Rico was designed to produce those results. And sure, there are plenty of mistakes that you can point at that people and leaders in Puerto Rico made. But fundamentally, it came down to Congress deciding that Puerto Rican lives matter less. So I want to introduce our panel, who's going to tell us more about what's happened after the hurricane. Dr. Carmen Zorrilla is professor of obstetrics and gynecology at the University of Puerto Rico School of Medicine. Dr. Jaime Torres is vice president of community relations and partnerships at Urban Health Planning. He's also the former regional director for HHS for Region 2, which is the region that includes New York, New Jersey, Puerto Rico, and the Virgin Islands. And then we have Eliot Fishman, who is the senior director of health policy here at Families USA. And as you heard earlier, he was also formerly of CMS. Please welcome them, and thank you very much for being here. Shall we start?
Timer. Whoops. Hi. Hola. Thanks for inviting me here. First, okay, let me go. On September 20th, Hurricane Maria hit Puerto Rico as a Category 4. It was a Category 5. Actually, the sensors and the radar broke down, so it was 4. But some people said it was also 5. Those are photos of Puerto Rico from the air, and you don't see. Is there a pointer? Is this? Okay, well, you see that blank space on the first slide, on the first photo on your left side? That's where the island should have been. It was as if a nuclear bomb attacked us. Actually, the power that a hurricane has been calculated equivalent to 10,000 nuclear bombs. And the power of a regular hurricane has been calculated to have the energy of 200 times the electric energy produced by the whole planet. So that's what attacked us and affected us. The hurricane was a catastrophic event, and we all have a collective experience of catastrophe. And we had a total loss of the power grid, which at the same time had total loss of water filtration systems and water pressure systems. So there was no running water, no electricity. Some of the communications towers were broke down, and also they had no power, so there were no communications at all. Loss of all the emergency systems, no communications between hospitals, ambulances, people, no communications within the island between government, mayors, anybody. There was only one AM radio station. If you were fortunate to have a radio station with batteries, you could actually listen to that one radio station. That was how we learned about what was going on. And the social networks provided some means of communication between people in Puerto Rico and the diaspora and people outside. Because there's no power, certainly if you have a power generator, you need gasoline or diesel. So the lines for gasoline took at least 7 hours just to get gasoline. And then it started being rationed, and there were lots of difficulties and violence related to trying to get gasoline. There were only 2 hospitals working in the first few days after the catastrophe. I'm presenting you baby Z. She was born at home 5 days after the hurricane. Baby Z was born out of a very young mother, adolescent mother, who lives with HIV. I run a clinic for women living with HIV. Her mother had a cesarean section 2 years before. She had this pregnancy. She had a planned cesarean delivery for after Hurricane Maria. She went into labor, called the ambulance. Ambulance never showed. She delivered at home with a prior cesarean section, a woman living with HIV on medications, the baby who needs medications as well, and all kinds of prevention to make sure this baby doesn't get HIV at delivery, at birth. She delivered at home. They had to carry the mother and the baby to a local health center where the umbilical cord was clamped, and then she came to our hospital. And that's if she allowed me to take a photo and introduce you to her, this beautiful baby girl that was born 5 days after the hurricane. And the baby's name is not Maria, of course. Nobody's naming baby girls Maria anymore. Some of these are photos from newspapers, and El Nuevo Dia newspaper decided to distribute its newspaper for free, and that was my source of information. The newspaper that I was running to get at the lobby of my building to find out what was going on, because it was just the AIM radio station and this newspaper. That was it. This is one article that I was fortunate to write about the perspective, my perspective from living during the hurricane and providing care at a hospital who started receiving all the pregnant women from the island who had no hospital to take care of them. And so we started receiving people from all over. So I just want to quote that I wrote there that we are not trained in disaster management. And we had to draw on our own personal and emotional strengths in managing the situation, aiming to provide high quality and efficient care while maintaining our professionalism, humanism, and empathy. These were very difficult times, the immediate aftermath, but it's been 4 months and some people are still living the immediate aftermath, and it breaks our hearts as providers. The impact of the healthcare system was huge. It dismantled, destroyed the healthcare system. It was completely blocked. Ambulatory services, preventive services, even elective surgeries were canceled for months. People who had to be scheduled for chemotherapy had to postpone. I know a person who needed chemotherapy, but she lives in a house where there's no power and no water, and her doctors told her, you cannot have chemotherapy if you have no water and no power. You will not be able to deal with the consequences and side effects of chemotherapy. So her chemotherapy has been withheld for 4 months. The press actually started talking about increased mortality, and initially it was denied. Now there's a investigation on the excess deaths in Puerto Rico. There were concerns with outbreaks. The most common infectious diseases on shelters are lice, conjunctivitis, and scabies. These are the most common infectious diseases that people have on shelters. There were outbreaks of infectious diseases that produce mortality, like leptospirosis that you get from contaminated water. And in spite of having 74 confirmed cases by a private laboratory who did the testing, the health department decided that because it was not their laboratory who made the test, they were not calling this an outbreak, much less an epidemic. And the epidemiologic surveillance system for dengue, for Zika, for all these vector diseases, it's not working. So we were living on remember I'm an obstetrician, I was dealing with the Zika epidemic that started in 2016, was still in 2017, even though cases were getting diminished. We had 3,000 pregnant women with Zika in 2016. We had about 1,500 or 1,200 pregnant women with Zika in 2017 until September. After that, we have no Zika. Of course, there's no testing, there's no reporting, nothing. These are the initial reports on the excess deaths after the hurricane. Certainly, we need to know that people did not die of the roof falling on top of them, or they did not get electrocuted by dealing with the cables. These deaths happened afterwards, in the aftermath of having a lot of elderly people without power, without water, so they were dehydrated. Probably some of them had heat strokes and so on and so forth. There's no way to go back to those birth certificates, because once it is written, you cannot modify or you cannot examine unless you check the experience. So this is a publication of a colleague of mine confirming that he calculates about more than 1,000 additional deaths in the aftermath of the hurricane. Mental health. It was very difficult for me to watch that video, and I keep telling all my friends that we have a collective memory and a collective experience of a catastrophe, and probably we have collective PTSD, because it's very difficult for us, even if we live in a bubble and we have resources and we have mental health, to go back to relive all these experiences. And people are still living part of that. So these are some of the comments of the patients that I have. I keep doing surveys on the patients in our clinic, and let's read one of them. I lost everything, but at least I'm alive. I have anxiety. I feel anxious, insecure, and I have stress. The last one. Sometimes I have bursts of crying. I feel desperate and depressed. Those are signs. That's a red flag for PTSD, absolutely. So we interrupted people who had mental health issues and needed medications, and so their treatment were interrupted. And probably we will have a lot of new cases of all kinds of mental health illnesses associated to the traumatic experiences that we lived and we continue to live after this hurricane. Another family that I want to introduce to you, these are these two beautiful baby girls, twin girls. They were born 2 days before the hurricane. And by cesarean section, one of the mother also has HIV. One of the baby girls was in the NICU, the intensive care, and the other one was in the regular nursery. So the hospitals needed beds, so they started making sure that people were able to leave the hospital. This family lives in Arroyo. If you look at that map of Puerto Rico, that red dot over there, that's the town of Arroyo. That's about 3 hours from San Juan, which is in the north. So, so they discharged the family with one baby, and when they got back home, they had no power, no water, no communications, blocked roads, and a person at the NICU told them that they needed to come every day to the hospital, otherwise they would be accused of abandoning their baby girl. So this family was coming every day with the other baby to the hospital to visit that other baby girl. Finally, they discharged the baby, and I was able to get this photo. They allowed me to introduce you to these two beautiful girls. To this day, you said 128 days. They have no power. They have no water. They do have cell phone, and their car broke down last week. They missed an appointment because they lack transportation. The story of the USNS Comfort, this is a hospital ship. Fantastic, and we're grateful that we had the opportunity of having this hospital ship sent to us, except that it arrived on October 3rd. It was, whatever the word is, sailing, traveling around the island, never docked. If you wanted to send a patient, you had to coordinate with one person who was receiving about 500 calls a day, 500 calls a day. The patient had to be transported by helicopter to the ship, and they specialize in trauma, so they would be gladly receiving people who had fractures and trauma. But most of the people who needed help, or most of the hospitals who wanted to send patients, had patients with chronic illness, elderly, with renal disease, heart disease, all kinds of chronic illness. Finally, after much back and forth in terms of let's redo the instructions and the rules of engagement, they were changed on October 30, 40 days after the hurricane, and the ship docked in San Juan, and that day it was like a chaos. It was like a fair, a long line of people trying to get to be evaluated at the triage. So we're grateful that we had this. I think the lesson from this is that we need to make sure that for emergencies that are not related to trauma or earthquakes, we need to have different rules of engagement. Slow progress. We learned this morning that we're not supposed to use too many numbers, but this is just a table that shows the slow progress of the recovery. In summary, on day 126, we have 85% power generation. That means the power is generated, but we have about 60% power access. So about 60% of households have power. We have about 90% water, and we have 90-something% communications by cell phone. So 4 months and 2 weeks. Let's compare what happened with other hurricanes: Sandy, Ivan, Katrina, Wilma. After Sandy, New York recovered 13 days. In 13 days, about 25% of people having access to electricity, 13 days. New Jersey, 11 days. Virginia, West Virginia, 10 days. After Katrina, the longest in the US had been Louisiana, 23 days for 2/3 of the population, or 75% of the population. So that's 23 days. The rest of the states, Texas, 16 days after Rita, and so on and so forth. So in general, historically, recovery from hurricanes in the mainland have been maybe about 2 weeks, with the exception of Louisiana, 3 weeks. Puerto Rico, 4 months and 2 weeks, and we still have 60% access to power. You do the math, you make your conclusions. Chaos brings opportunity to good things and to bad things. You know, we have both. Among the difficulties that chaos brought us was decreased access to medications, decreased access to care, stress-related illnesses, infectious diseases. And one story I'm gonna make, because I cannot not say this. In one of the shelters, there was a doctor, a fake doctor, who said, "Oh yeah, I'm a doctor. I don't have a license, but I'm a doctor. I studied medicine, and I'm here to work. I'm a friend of the mayor." And then he got into this shelter. And I don't know if he was a friend of the mayor or not. So we did not, you know how I found about this? I do have a group of friends from New York who went as a brigade to this shelter. And then this doctor started making orders and wanted to have some sedatives on this patient who had pulmonary embolism and a heart problem. And if the nurse would have given these sedatives, she would have killed this patient. And this nurse was part of this New York brigade, and they told me about this, and they stopped following the orders of this fake doctor. I would not have minded if he didn't have a license, if he had the knowledge. The problem was that he did not have the knowledge to deal with the emergency, and he was embedded as a doctor in a shelter. Mixed messages: everything's fine, everything's not fine. So we do have an opportunity for redesign the system. We have an opportunity, certainly, to engage faith communities and community organizations in the recovery, in the solution. By the way, community organizations and faith groups were close to the community. They know the needs of their people, and they were really very helpful in the initial steps of the recovery. And certainly we need to reinvent the power grid and all of that, the management of the power grid in the island. I want to end with this. Sometimes one of our ways we release the stress is through humor. And there were plenty of humor messages in the social media. One of my favorites have to do with the Star Wars fan. And so one of them, the third one from left to right on top, says, "You completed your training. More than 70 days without light. Welcome to the dark side." Another one below, the new baby, the power generator. That was, people got their power generators. Finally, I have a power generator. The middle one in the lower segment is a new electric power company employee, an iguana. And And in the middle also, the dogs making a line because there was only one tree remaining after the hurricane. So our new normal, long lines. I'm so fortunate and blessed that I live really close to the medical center because I decided I was not going to make a 7-hour line to get gasoline. So I waited and I was lucky. But we do have lines for everything now. We don't have, you go to any supermarket, you don't see everything available. You still lack stuff. There's recovery efforts and there's hope. And finally, I want you to know Yvette. She is one of the AIDS activists from Puerto Rico, Yvette Gonzalez. And I'm going to read from Paulo Coelho, my favorite author. And he said, in order to live fully, it is necessary to be in constant movement. Only then can each day be different from the last. Thank you so much.
Buenas tardes. I'm so glad to be here and so glad that Sinsi took the leadership in taking this panel together for something that means so much to many of us. So, as you can see, we're still recovering from one of the worst natural disasters in the US. This disaster really has set us back 30, 40 years, I would say. So as we learned over most of the electric grid was destroyed. Right now, over 100,000 homes were badly damaged or destroyed. And for months, you saw things like these, people carrying water from the river. Their first photographs is in the 1940s from Jack Delano, and this one is last October. But before this natural disaster, Puerto Rico had been enduring a man-made disaster that had destabilized our economy, our citizens, and our health care. In 2015, the government of Puerto Rico declared bankruptcy, which may become one of the largest in US history. And just to compare, the bankruptcy in Detroit was $18 billion. So what you hear about Puerto Rico is our debt is $74 billion. But there's more than that. There's $53 billion on unfunded pensions liabilities. These are the people who are ready to retire. The population shrunk close to 15% in the last decade. Our poverty rate is still 46%. And the governor just announced yesterday that he expects the economy to shrink 11% and to have another drop on 8% of the population by 2019. But one of the principal and often unnamed causes of the fiscal crisis is a federal policy which provides unequal treatment to the territories when it comes to Medicaid funding. Puerto Rico spent over $19 billion from 1998 to 2013 to cover the local share, to cover the indigent in Puerto Rico. Healthcare, this health crisis did not begin a year ago or 10 years ago, but much longer. First, Puerto Rico is a US territory, and therefore the rules and fundings are different from those of a state. We have been US citizens since 1917. We had fought in every war where America has been involved, but we cannot vote for a president, and we have no representation in Congress except a non-voting commissioner. Medicare and Medicaid reimbursement are different for the territories, even though our cost of living is comparable to the state and sometimes even higher. So I will just comment now on the Medicaid disparity, which is huge and unacceptable. And if we don't receive funding from Congress, it may result in 500,000 people becoming uninsured by the end of this year. And so you know, Puerto Rico has one of the lowest uninsured rate in the nation, around 10%. By stature, Medicare federal match for Puerto Rico, the FMAP, is 55%. If it had been a state similar in population and poverty rate like Mississippi, the federal match would have been 75%. To add insult to injury, the territories are subject to a ceiling cap. $330 million for Puerto Rico. That's it. All the money you're going to get. Puerto Rico currently provides managed care Medicaid to close to 1.6 million residents for an annual cost of $2.5 billion. But remember that by statute, we can only get $330 million to cover those people. This chart shows the Medicare funding without the Affordable Care Act funding, what I will mention in a minute. So we have the first line is Medicaid for a few years. The second line is CHIP. We only get $150 million. And the third line is something called the Enhanced Allotment Program, which is to pay for prescription drugs for coverage for the dual eligibles, because we're not eligible for the low-income subsidies like in state. It would have been a lot more money. Meantime, the passage of the Affordable Care Act gave a temporary relief to the territories. Puerto Rico received a $6.3 billion grant in 2010 for a program that was already in crisis. The ACA funding is expected to end this April, 3 months from today. So that's what I mean. When that money runs out, 500,000 people may become immediately uninsured. So this crisis has been foretold for a while. This is a report from the Commonwealth of Puerto Rico in 2014, where it shows very clearly that Puerto Rico was getting $1.6 billion from the federal government, and without that, it will become a crisis. This was my opening slide at a presentation I gave at the Puerto Rico Hospital Association conference in January 2014. The only thing that changed is that I put an X over the 2019 where the ACA funding was going to end, and most likely it will be in a few months from now. Meantime, the ACA funding was expected to end in September of 2019, but of course, because of the Puerto Rico bankruptcy and the need to use all the federal funding, that money will be spent sooner than later. But meantime, after this presentation, there was hardly any effort from industry, medical groups, and advocates to come to Congress and ask for a change in statute or get more funding. There was a thought the Obama administration is going to come through and solve this. It did not happen. Like I mentioned, yes, Puerto Rico received ACA funding, which was a temporary relief to help an already system in crisis. Please note that if you compare a state similar in population and poverty, like I mentioned, Mississippi, Mississippi got $3.6 billion. Puerto Rico got $330 million, okay? If you compare it to Oregon and Oklahoma, you can see also the disparity in terms of funding and the FMAP. One of the main reasons that providers are leaving the island is reimbursement, not only in Medicare, which is a different subject, but Medicaid. In Puerto Rico, a payment for per month, per member, per month, per patient is $165. But if you compare that to New York, over $1,000, or New Jersey, $366. So it is more appealing for a provider to maybe come here and work. So this graph is just a visual in what will happen when the funding will run out. So the red bar is the funding by Puerto Rico, the green is the Medicaid funding, and the blue is the ACA funding. But again, when that bar in 2019, if it happens, the red bar will be the responsibility of the government in Puerto Rico, which they do not have the money to even cover half of that as of this moment. This is a graphic that it tells you a little bit of the stories. For example, so this is Medicaid spending. If we were getting the funding for the affordable funding from Congress, the line will continue straight. Without the additional funding, it will become the blue line. But without the funding and without Puerto Rico extra funding, we're talking about really a fraction of what will be needed to cover the 1.6 million people in the island. And this one, this one is the, let's see, enrollment, no. So this is, again, the number of people. Again, this is how many people will become uninsured. First, if money continues, then if no funding, but Puerto Rico is able to sustain some of the funding, and the orange one, if there's limited funding in Puerto Rico and no funding from the federal government. So migration, so by now, you've heard over 250,000 people have left the island, but this has been going on for the past decade. So in the past 5 years, you can see the numbers, around, by 2014, over 60,000 people had left the island. This is a profile, this is a brain drain also. Some of the more well-educated younger people are leaving the island, but they're also some of the poorest ones. And know that 60% of those people are eligible for Medicaid, so when they come to Miami, they come to New York, the cost on those states is going to be astronomical, as opposed to being able to support Puerto Rico, where we can keep the same population at a lower cost. So in conclusion, and this is a report that came from the US Department of Health and Human Services in January 17, they stated very clearly, the imminent exhaustion of additional federal funding threatens the safety net, with nearly 900,000 people potentially losing coverage. This is so, if we don't get $3 billion by 2019, close to 1 million people will be uninsured in Puerto Rico. And this is some of the medical conditions, some of the stats of the people that, why this is so important at any population. But look at the high rate that we have of diabetes, hypertension, asthma, depression, and all these numbers were before Maria. So we need your advocacy. We need your voices. And probably Eliot will say more about this, but in the recent backs and forth in Congress, originally there was $1 billion in Puerto Rico that was going to be included in the SHIP reauthorization. That did not happen. Well, the hope is right now that there will be at least $3 to $5 billion when they deal in Congress before February the 8th, probably for 2 years. So this is part of the efforts that we need to make sure that our voices continue to be raised. So we are resilient. We're going to rise. And one of the things that, as many advocates who have been hitting Congress, you go and visit the office, and one of the questions that I've been asked, which I find quite offensive, is, what do you want? What do you want? That, as we know from this morning conference, that this is not the right question. What has really impelled me for many years to do this job is a question that the philosopher Eli Siegel said that he says is the most important question in ethics. What does a person deserve by being a person? ¿Qué se merece una persona por ser una persona? That was a question Eli Siegel said is a central thing that should be discussed. We deserve housing. We deserve funding to cover our Medicaid population. We deserve schools that are open with electricity. We deserve that every house in Puerto Rico has electricity. We are the United States. We have the potential to bring an army there to do this work right now if we want to do so. So we need your voices. We need your advocacy. And Sinsi, thank you so much for having us begin this conversation here.
Okay, it looks like we have the the wrong presentation loaded. I'm just going to start talking while hopefully we get that fixed. So I'm going to talk about two considerations, one specific to Puerto Rico and one with implications for the national debate over block grants and per capita caps in Medicaid. I want to talk first about what Puerto Rico's current legislative prospects are on Capitol Hill, what's moving now. And I also want to contextualize what Puerto Rico's experience has been year by year over decades in the debate that we just had this past year, and there's a good chance we will have this year, and if not this year, sometime soon, around the fundamental structure of the Medicaid program. So first, in terms of what Puerto Rico's asks are going forward, the overall point that I want to make, I'll go back to the Stokely Carmichael quote that Senator Cory Booker made reference to yesterday morning, that he wouldn't even use the word constitution in the context of the civil rights battle. He could only say 3/5 of the word constitute. So what Puerto Rico's current legislative ask is not even parity, right? It's 3/5 of the word parity, pare. It is first that at least the cliff that Puerto Rico is facing in terms of the removal of the ACA funding, which is now looming imminently, that get reversed in whole or in part, right? And again, as Dr. Torres went through, Puerto Rico was in crisis with that ACA funding, right? In terms of the medical system, with providers leaving, and I will tell you, when I worked at CMS, there were a lot of discussions about trying to undo what Puerto Rico was facing, even with that ACA funding. And that doesn't even count. Go back to what Sinsi said in her introduction. Puerto Rico does not even have a Medicaid-funded LTSS system. Right? What happens to people with disabilities, to seniors who need long-term care in Puerto Rico? We don't even really know. Right? That's the answer from a national policy perspective. So, and that stems not from Hurricane Maria, not from Hurricane Irma, not from the loss of ACA funding, but from the basic structure of a block grant that falls further and further behind the cost of healthcare every year, and from a match rate that would be, if Puerto Rico were in the state match rate system, would be one of the lowest match rates that any state has. And just mathematically, that results in the state's costs being higher by a factor of about 3 relative to what they would be to draw down federal dollars if Puerto Rico were on a parity-based system in terms of match rates. Right. So the first ask that Puerto Rico has is just for relief in terms of that cap funding. The next ask is for temporary relief in terms of that match rate, right? To move to 100% match rate on a temporary basis. That is not an unprecedented ask. That follows on precedent set with Hurricane Katrina in terms of the impact of death toll. Hurricane Katrina, we now know, is comparable to what Puerto Rico has suffered. In terms of the impact to public health infrastructure and sustained impact to public health infrastructure, what Puerto Rico is going through is even worse. So again, it's not even quite asking for parity, and none of these asks are unprecedented. Puerto Rico is also asking for, and by the way, I should note that these all are documented in a letter to congressional leadership that Families USA and hundreds of other organizations have signed on to. and which documents not only the specific asks, but the precedents for each of them. Puerto Rico has asked for people who have left the island to, Dr. Torres mentioned, to Florida, to New York, elsewhere in the United States, that those evacuees receive also 100% match when they use Medicaid services in the respective states to which they've evacuated. That again follows the Katrina precedent. Puerto Rico has asked for a number of measures to significantly simplify, there we go. Simplify the Medicaid eligibility determination process. That follows precedent not only in Hurricane Katrina, but in September 11th in New York State. Simple asks that Medicaid eligibility can be moved to an attestation basis, which flows directly from the impact on the state's ability to quickly process Medicaid applications. And because of the difficulty of processing Medicaid applications in an environment where there's not a lot of electricity, also would involve relief on redeterminations of Medicaid eligibility and simplified application process. Many of you, as I was, were involved in dealing with problems with the implementation of the new rules around Medicaid eligibility determinations at the end of 2013 and the beginning of 2014. You know that there was a federal executive branch relief using some statutory authority through the Affordable Care Act that allowed states to delay redeterminations in some cases for years, that allowed them to move to simplified eligibility procedures on an emergency basis. None of these asks, just to underline, is without a precedent, a recent precedent from another state dealing with a similar or lesser in scale problem around either their IT systems or in terms of a humanitarian disaster. So Puerto Rico's core problems have to do with a fundamentally disparate and unfair Medicaid financing structure. Puerto Rico's short-term asks have to do with fundamentally asking for similar established pathways of Medicaid administrative and legislative relief that we have experienced in the last 20 years. And the final ask has to do with funding for healthcare reconstruction. Again, this is something that was forthcoming and legislated in, certainly in Hurricane Katrina. There was a substantial Medicaid waiver that involved a lot of support for healthcare reconstruction, and in September 11th as well. So, current status. First, the continuing resolution that allowed the government to stay open through February 8th was very disappointing, did not include any meaningful relief for Puerto Rico and the United States Virgin Islands. As Dr. Torres mentioned, there is hope that we could see in a supplemental bill, together with other healthcare funding extensions, that we could see some relief for Puerto Rico, but note that a bill passed the House that was sharply limited, fell far short of the eminently reasonable asks that are currently in front of Congress. So I'd ask you both for, as I think we're collectively asking you, for your advocacy resources to be pointed to the immediate problem facing Puerto Rico in Congress. But I'd also ask you to have this in mind as we are advocating around the structure of the Medicaid program, right? When we talk about how people from all walks of life are affected by Medicaid, when little lobbyists talk about children with disabilities, when we talk about people with HIV, pregnant moms, seniors, people with disabilities, Puerto Rico is living on the other side of the looking glass in those debates. So that is, of course, of urgent and immediate necessity to at least ameliorate in Puerto Rico, but it's also an extraordinarily powerful cautionary tale for what we have been fighting against and what we are going to continue to be up against. Thank you.
Thank you, three of you, for helping us understand the full scope of what's been happening there and the implications that the Puerto Rico lesson can teach us about the perils, the grave perils of having a block-granted Medicaid program. I'm going to borrow a little bit from Patrick. He was saying, what does democracy look like? And I think we need to talk about, what does a Medicaid block grant look like? And what's happening in Puerto Rico is what a Medicaid block grant looks like. So I would like to get a little bit of, mostly have a little bit of a dialogue now, but especially get an opportunity, some time for questions from the audience. So one of the things that I wanted to ask was, in terms of what's happening right now, I wanted to ask Dr. Zorrilla, in terms of what's happening right now and kind of being in survival mode when it comes to the healthcare system, have you seen much activity around going beyond just the immediate crisis and thinking about organizing to solve the broader, underlying funding issues?
That's a difficult question for me because I am not part of the government at all, and I am not part of the plan, whoever is planning these strategies. As a person who lives in Puerto Rico, person who provides care in Puerto Rico, I can tell you that I have not heard any coordinated efforts towards actually trying to push for us to get what we deserve, not what we want, but what we deserve. And it's very frustrating, and actually I just want to say that I thank all of you for having this conversation and for whatever help you can provide through the advocacy that you're doing, because I think it's eventually to the benefit of everybody, not just people in the small island, but the whole United States as well, our nation.
And Dr. Torres, can you tell us a little bit about what you've seen? And you had a lot of experience a few years ago under the Obama administration helping to administer the HHS programs in Puerto Rico. And then now we're in a different situation. And you and I spent a lot of time talking about what needs to be happening. Because obviously, if you're worried about just getting gas for your generator, you are not worried about how am I going to call Congress, or how are you going to advocate in Washington, D.C., which is where where the checkbook really is, right? Yes. So tell us a little bit about the efforts that have been happening here in Washington and on the national scale.
So let me go back to Puerto Rico. I think that one of the things, we all have been affected, and I think I have been involved with many people here, many people in the diaspora trying to help Puerto Rico, and one of the things that have been very heartening is the amount of providers who have gotten out of their offices, gotten out of the hospital to go to the mountainsides to find the people there. And I think it's very clear that going forward, the same way we're trying to reform the electric system in Puerto Rico, we need to reform the healthcare system.
Absolutely.
Facing with the new reality of this crisis in funding. Regardless if we get the funding from the Congress or not, we need to have a new paradigm on how to provide services and to emphasize, again, a public system in such a way where public health will be emphasized, like it was many years ago. If you know this very well, Sinsi, that Puerto Rico began to change in the 1990s, where we changed from maybe a deficient public system to more privatizing and trying to provide insurance for people instead of better access. And so we have adapted, taken the most expensive qualities of the main of the healthcare in the United States. Meantime, we're not able to afford it. So that has to change right now. So, and also that implies also changing how we are going to pay for nurses going to outside the office, maybe community health workers, how to be able to pay for their services, and extenders that will be able to go to a mountainside and check the blood pressure or the sugar of a patient on the spot, as opposed to spending a whole day going to a doctor's office and you know you spend the whole day there. So I just want to emphasize that regardless of what happens right now, that conversation has to begin. In terms of the advocacy, I think with many people here, we've been knocking doors, and we have many advocates. We have many friends on the Democratic side. We have some friends on the Republican side, and I would say that both senators from Florida have been quite supportive. I mean, because again, most of those people who have left Puerto Rico ended up in Florida, so they have been supportive. I think that there have been so much that we have been advocating for, CHIP, Medicaid, and all that, that I think Puerto Rico can get lost. So the main thing is right now, we need your efforts. We need your voices right now before February the 8th, because we need to pass funding to cover immediately those probably 500,000 people who might become uninsured when April comes and there's no funding to cover those residents.
Thank you.
And I'm going to, something we could, you know that we agree to disagree, the matter of the block grant. I know that people want to see this model as something not to follow, which I understand completely. But Puerto Rico is not a block grant. It's worse than a block grant because, yes, you have limited funding, but you don't have the flexibility. You have to follow the same rules that CMS, thank you, CMS had, and you have to follow the same rules, so you don't have that flexibility. So it is it's even worse than a block grant.
May I add something?
Sure.
Thank you so much, because you're the experts. I would say as a provider and as a person who's been trying to change the system in my own environment, like implementing a program of group prenatal care and starting a clinic for women living with HIV, I think we can use this opportunity of redesigning the healthcare system to make it patient-centered, to involve consumers, to give power to the people who are really receiving the care. And that's a culture that has to change. And I think we do have an opportunity, and given the opportunity, I would jump into changing the culture as well, not just the resources, but the way we do things.
Eliot, I was hoping you could talk a little bit more about the parallels you see and the perils between what, and Jaime is very correct that it's worse because you don't have flexibility, but I think also the idea of flexibility is a little bit of a red herring as well. So can you speak a little bit about what we can learn from the situation and how advocates can utilize this crisis in advocacy around protecting Medicaid as an entitlement?
Yeah, so a couple of notes on that. One is, so some version of Medicaid block grants and Medicaid per capita caps was in every repeal bill that went through the House and Senate last year. There wasn't a lot of actual flexibility attached to any of those proposals. So the trade-off of caps for flexibility, I think is somewhat mythological, not just in Puerto Rico. You know, I think that it's the other connection that's important to emphasize with Puerto Rico is how the entire healthcare system winds up just severely damaged and at risk, right? That Medicaid is, of course, a program about low-income people. And, of course, it's also a program about some sympathetic middle-class populations. But it's also a program about keeping a healthcare system functioning. And that is a very important message that Puerto Rico brings to life very vividly. the last thing I just wanted to take note of, it's not directly responsive to your question, Sinsi, but it just comes through in the answers that Dr. Torres and Dr. Zorrilla just gave, and it's completely consistent with my experience talking to Puerto Rican healthcare leaders and governmental leaders, is the positivity and practicality of the people who are trying to keep things going in Puerto Rico. And that is inspiring and instructive for all of us in this room in a different way. Really, as outrageous as the situation is, it continues to be as we get around the table to try and advocate for Puerto Rico in 2018. Really just incredible lessons of hard-headed, practical, not self-indulgent advocacy from the people who are leading this effort from Puerto Rico.
So I think we have time for some questions. If there's, I can't see because the light's in my face, but I know there are roving mics
in front of you
around.
I'm Mark Hannay. I'm Director of Metro New York Healthcare for All. Hello, Jaime. Good to see you again. I'm sort of wondering how much of this, you all kind of touched on this a little bit, but I mean, this healthcare crisis in Puerto Rico exists in a larger context of historical de facto colonialization. And so I know there's been some discussion of that theme in the aftermath of Hurricane Maria, but I'm sort of wondering, is that connecting to this conversation around healthcare, and how is that connecting? And
So if your question is, how does this relate to the status debate? Is that what you're? No.
It's more radical than that. It's Mark Hannay, it's more radical. Look, Mark, of course it is. I don't think this is even, it's a very difficult discussion to have, and I think we need to set our priorities, what we're going to be fighting for right now, immediately. And even the more milder question about are we going to become a state or independent, that's something that even right now is rearing its ugly head right now, which is not the moment to have this conversation. The main conversation is how to make sure we have housing for Puerto Rico, how we have electricity for Puerto Rico, how we have healthcare for Puerto Rico. We're going to get to the other discussion down the road.
Hello, my name is Max Trujillo. Good to see a couple of you. It's been a while. I want for the panel to elaborate on a couple of points that have been raised. One, in terms of the block grant as an example for the US, I think Sinsi, maybe you can elaborate a bit more on the consequences of having a block grant and how does that impact the medical special programs, particularly for the subsidies for Part B and all the other Medicare expenses. I don't think that people understand the real fear of God on this. In terms of the point that Jaime raised regarding the supplemental, I would just encourage people who are fighting on that fight not allow you to be dissuaded that there's going to be another supplemental later on for Puerto Rico. The fight is now, and you have to fight now for the money. Don't let them seduce you that there'll be a special one with more money later. For Puerto Rico, later never comes.
Yeah.
Right.
And third, I think that this is more of a question of prospectively. In the presentations, we mentioned all the crises that took place while the hurricane was taking place. The hurricane, we're in February for all intents and purposes. The hurricane season starts in May. What have we learned from all the chaos that took place that we can suggest to the Puerto Rico government and to FEMA in terms of what are the steps that are needed now so they can address those issues when they come again in May, June, July? And I just want to raise as an example, there was a lot of panic that there were no vaccines at one point, and then the CDC was nowhere to be found, and the Puerto Rico Health Department wasn't able to express what was going on because there was no power, no radio stations, no TV. So I know I threw out a lot, but I think those are very important questions that I hope the panel are able to explain. Thank you.
Okay, I should have had a notebook to take notes because that was a multi-part question. The first thing on the issue of the fear of God around what a Medicaid block grant is, I think that's a really good point because a lot of, there are a lot of people who don't necessarily, who take for granted all the different programs that are funded through Medicaid that are not just the Medicaid coverage, right? So for example, as you were saying, there are the programs for low income, the SLIMB and QUIMBY programs, which are for low-income dual eligibles, and even those who aren't eligible for Medicaid, who are just a little bit above it, that get help from Medicaid to pay for their Medicare Part B. They get help to pay for their Medicare Part D. That just doesn't, we don't do it all in Puerto Rico right now because the money, it's not long enough. And then we have other programs like for special ed, for example. There's a lot, special ed kids in Puerto Rico get a really short end of the stick because in the States, there's a lot of services that special ed kids get in schools that are reimbursed by Medicaid. That's not an option either, let alone, just as we said already, being able to cover long-term care at all. And I only remember that first question. I lost about the other two. So hopefully some of the other panelists remember the other two questions.
I want to respond to the one that we're already close to the next hurricane season. And we're already talking about it. It's 4 months till the next hurricane season starts in June. And so certainly we need to restore the power and prepare for what might be lost again if we restore it as it is. We need to restore and improve. We need redundancy in the communications. Let me give you an example. The emergency medical system decided at one point, because it was too expensive to have communications by radio telephone, that they decided to keep just cell phones. When cell phone towers went off, there was no emergency medical communication. So we need redundancy. Even satellite phones don't work if there are clouds. So we need satellite phones, we need radio telephone communications, we need to make sure that the cell phone towers are strengthened and all of that. So we need redundancy in the major elements that will keep us surviving after a hurricane, which is power, communications, and water system as well. So those are things that I'm not sure that we're getting ready for that because we don't have the resources. Certainly we know we need them. We need now protocols work, hospitals are working on protocols. People need to know, if you don't have power on this hospital, where do you go? If there's no place to go, where do you go? Nobody talked about that. The health department was not able to communicate anything during or after or even prior what to do in an emergency. Those are things we can prepare for.
And we also need to make sure that the USS Comfort is not in dry dock in the middle of a hurricane, right? And it takes 2 weeks for it to get there.
Or to be cruising around without seeing patients.
Cruising around without seeing patients. So I'm being told that we need to wrap it up. Thank you very much. As somebody who for now like 7 years has been not really able to have a space to work on making sure that the healthcare de mi gente en mi patria is taken care of. I want to thank Frederick. I don't think he's actually here, but I want to thank Frederick very much for opening this space and basically pushing us, saying that this is the biggest healthcare crisis in the United States right now, and we need to do something about it. I hope that you all join us in doing something about it, and we hope to hear from you very soon. Thank you.
Thank you, Sinsi. And so if we could have another round of applause for our panel. So we're wrapping up today, and we will not be back in this room tomorrow, which is one of the reasons why we have to get out of this room now so that they can get it ready for a different group. Tomorrow we will be in the room where everybody had their mac and cheese. And so we'll have that for our final plenary sessions. At 5 o'clock, the California Caucus will be meeting in the Thornton Room, which is across the lobby. Take the elevators up to the top there. Again, tomorrow we will have breakfast roundtables and some fun runs. So thank you all, and we look forward to seeing you tomorrow. Thanks so much.